Hello, my name is Maximilian Pfau, and I will go on now with the second part of vision testing in AMD. My talk will focus on microperimetry in intermediate AMD and geographic atrophy, as well as color vision testing in AMD. So what is the key motivation for microperimetry? Most visual function tests, which you heard in part 1 about, are feasible, are relatively simple to implement, like best corrected visual acuity. However, it's always important to remember that best corrected visual acuity testing provides no spatial resolution on the retina, so you don't gain any information where spatially on the retina you have your treatment effect. Treatment effects can be caused either, for example, in neovascular EMD by fluid going back and vision getting better at one spot, or the preferred retinal locus changing its position in the eye. On the other hand, with microperimetry testing, you have simultaneous imaging of the back of the eye, you do visual field testing, and you can test multiple points at the back of the eye. So you gain a spatial resolution, you have stimuli with a diameter of 125 microns typically, which would be a Goldman 3 diameter, and you can cover up to 68 or 100 stimuli within an examination time of about 10 minutes. What is the principle of microperimetry? Microperimetry is essentially visual field testing, so you present stimuli, which are bright in the beginning and get increasingly dimmer, and the patient has to press a response button to indicate whether he saw or whether he didn't see the stimulus. The difference to regular visual field testing and microperimetry is that you also have an imaging unit, so you can simultaneously track the retina and you can always place the stimulus at the correct position, even if fixation is unstable. As a result, microperimetry provides three main advantages. It improves the intra- and inter-session retest reliability because you always test the same location. It allows for precise structure-function correlation because you know where you are. And it also enables testing in patients with unstable fixation. The idea is actually quite old. Already in 1851, von Helmholtz came up with the idea when he invented the ophthalmoscope. In the very same article, he also described that when he covered with the ophthalmoscope the optic disc, you could see the natural blind spot scotoma, and by using this direct ophthalmoscopy, he could demonstrate for the first time in vivo that the blind spot actually corresponds to the optic nerve head. Later on, early microperimetry systems were implemented in fundus cameras in Japan, and then Timberlake provided the first prototype based on a scanning laser ophthalmoscope. Today we have multiple generations of clinically available devices. The most important devices are the two you see on the lower right, the S-Maya and the Maya 2 device. So the S-Maya is the scotopic implementation, the Maya 2 is the same device but just for mesopic testing, and then the MP3 device. It is also important to consider the principles of selective perimetry. Typically in perimetry, especially in mesopic or photopic testing, you test mostly cone function. If you do photopic white on white testing or red on white testing, you really isolate cone function, and as a result, if you look at the normal data, you get this normal hill of vision. For AMD, you can also perform scotopic testing, which allows you to isolate rod photoreceptors. The principle is that once you dark adapt the eye, the rods become more sensitive by about 2 log units than the cones, and the most sensitive wavelength for rods is in the range of about 500 nanometers. That's why you typically test in the dark adapted eye with sign stimulus to isolate rod function. If you then look at the normal data, you see this typical profile with a scotoma in the center corresponding to the rod-free zone, and then increasing sensitivity as you go towards 10 degrees eccentricity. Regarding the current generation of devices, the two most important devices for clinical trials these days are the Maya 2 device and the MP3 device from Nidec. They're overall very similar. The Maya 2 device unfortunately only allows for mesopic testing, but it has a very good dynamic range, is relatively easy to use. The MP3 device offers a bit more flexibility, also allows for photopic testing. However, the menu given the increase in flexibility, is also a little bit more complicated, but overall both devices perform well. There's also the new Maya 3 device coming up. It has been announced to be available on the market in 2025. And an important feature of the Maya 3 device is that in the pre-market authorization study, which also served for its approval, it was demonstrated that it yields the same sensitivity measurements as the Maya 2 device. One aspect which is very much underused in clinical development and research these days is specific testing patterns. In microperimetry, you essentially can add any testing pattern. What is most commonly used is what you see here on the left, the rectilinear pattern, like for example here the 10-2 pattern with 68 test points spread evenly across the central 10 degrees, or radial patterns. It's always important to notice that these rectilinear, evenly spread patterns make sense in diseases where the disease somewhat spreads evenly across the macula, maybe for example progressing geographic atrophy, while these radial patterns make sense if you want to give more emphasis to the fovea or parafovea, if you want to have a higher density there, which of course makes a lot of sense in exudative maculopathies. But there are also other patterns to consider. For example, this profile shown in the upper right makes a lot of sense in inherited retinal diseases because retinitis pigmentosa typically presents in a very symmetrical ellipsoid shape and can be tracked much better with such a horizontal profile than with a widespread pattern. Regarding intermediate AMD, there is considerable data out there. The test-retest reliability for a single test point is in the range of 4.5 to 5 decibels. There are a large number of studies that establish the current validity of mesopic and scotopic microperimetry in intermediate AMD. Essentially, they show that there is a strong association, especially with dark-adapted sensitivity loss, with localized presence of subretinal drusenoid deposit, usually resulting in quite a heavy sensitivity loss, about 5 or more decibels. In the upper right, you can see an image of an eye with reticular pseudodrusen in the upper nasal quadrant, and you see corresponding in the lower row the sensitivity loss. It is also well established that you can measure change over time in intermediate AMD. In the lower right, you see these 3 panels from the Duke feature study from Eleanor Roulette. And first of all, you have a panel for normals, then you have a panel for intermediate AMD and a panel for early AMD and a panel for intermediate AMD. And you can see that these panels all differ in sensitivity, and then within each panel you can see that there is, especially in the intermediate AMD panel, progression over time. A new development which is extremely promising is this concept of targeted perimetry in intermediate AMD. Of course, in intermediate AMD you have often localized defects once intermediate AMD slowly progresses towards geographic atrophy, typically, for example, a drusen that collapses or where nascent GA forms, and at those spots you have localized defects which you would miss with a large grid spread across the macula. So here you can see an example of such a targeted grid developed by Sichao Wu and Robin Geimer's group, and you can see that you capture much more localized dysfunction. Currently, this approach is evaluated prospectively in the HONU study. Another study where this concept of target perimetry was evaluated is the Pinnacle study in Europe. And again, what we have shown in this first report of the Pinnacle study is that if you interpolate sensitivity across loci and then compare it to an actual measurement using this targeted perimetry, that with the targeted perimetry you can capture dysfunction which you would otherwise miss. Again, this is a very promising approach if you think for any therapy where you want to slow the progression of a high-risk lesion within intermediate AMD going towards geographic atrophy. In geographic atrophy, you can of course apply standard grids, like here the 10-2 grid with 68 points across the central 10 degrees. And with those standard grids, you can measure change over time. However, the rate is quite variable and it's rather slow. It's about -1 to -1.5 decibels per year. instead of taking the sensitivity from each point, you can also differentiate between points where the patient responded, so he saw any type of light blindness, or where he couldn't see any light at all, so there was no response, indicated by less than 0 decibel sensitivity. And those non-responding scotomatous points, they progress with this grid in a typical GA patient by about 4 to 5 points per year. Again, it works in principle, but not ideally or perfectly suited for a smaller phase 2 trial. What could you do in such a trial? One way to increase the change over time is this analysis of perilesional sensitivity, as first proposed by the Moorfields group. And what you basically do, you select the testing points around the scotoma at baseline. You can define the baseline scotoma either in terms of the points with 0 decibel sensitivity or based on imaging wherever the geographic atrophy is, and then you look at the points directly in the junctional zone. And if you do such an analysis, the progression rate is much quicker than looking at mean sensitivity overall, and the rate of change increases to minus 1.5 to minus 2.5 decibels per year. On the lower right, you see an image of an analysis done in the chroma spectral trials, and again you see that these perilesional sensitivity measurements show much greater change over time. My own research group also developed an approach, however it is in that sense much more sensitive because it's a prospective approach towards measuring the perilesional sensitivity. It's this concept of patient-tailored perimetry, where you first take for each patient the baseline imaging data, and then based on these baseline imaging data, you design according to a preset rule set a patient-tailored grid, and then you can test this patient-tailored grid in a patient. And it has, compared to this other retrospective junctional zone analysis, the key advantage that you actually maximize the number of test points in the relevant junctional zone, and you still can minimize the overall number of test points. The only disadvantage is the technician at the device must accurately place the grid. Here you can see the workflow, how it is nowadays implemented in clinical trials. So basically you have a screening visit where imaging data is taken, then the reading center annotates this baseline imaging data and creates a patient-tailored grid. That grid is sent back to the site runs the grid, the reading center confirms that the grid position is correct, and subsequently just the follow-up mode of the device can be used. What you can also do with these patient-tailored grids, or also with any other grid, can look at the spatial pattern of sensitivity loss, also for scotopic microperimetry. And what you see in these plots on the upper right, you see on the x-axis the distance to GA, on the y-axis the sensitivity loss. You can see that you have severe sensitivity loss in terms of mesopic sensitivity close to the GA boundary, but then it quickly levels off. But when you come to dark adapted sign sensitivity loss for rod dysfunction, it's much more severe, and also the increase as you go further away from the GA lesion is much more slower or protracted. If you look at the panel in the lower right, you can see a plot of dark adapted sign sensitivity loss on the x-axis, reflecting rod dysfunction, and mesopic sensitivity loss on the y-axis, reflecting mostly cone dysfunction. And the interesting thing is, it's a curvilinear association, and you can see a lot of test points that have dark adapted sign sensitivity loss, so they have rod dysfunction, but they still have normal cone function. And only once this rod dysfunction goes lower than minus 16 decibels, that's when you typically see also cone dysfunction. So scotopic microperimetry in GA, but also in intermediate AMD, it can really help you to study the disease sequence. And it's important to understand that sign sensitivity loss or rod dysfunction occurs much earlier than cone dysfunction, which again fits to the dark adaptometry data, which Professor Orsley showed you in the talk part 1. Another option to test function in geographic atrophy over time is this concept of high density super threshold perimetry, also proposed by Xichao Wu. And the principle is, instead of doing psychophysical testing where you test each step of the sensitivity scale, you simply select a very bright stimulus, for example, the 0 decibel stimulus or the 10 decibel stimulus, and then you show each stimulus just once, and the patient has to press the button if he saw it or not. And that way the test goes extremely fast, and you can test a lot of test points. And it's also fun to do that test because it feels as like a relatively easy test, because either you see the stimulus or you don't see it. You don't have those stimulus which are just at the threshold and difficult to detect. So it's fun for the patient and you get a lot of information. The only disadvantage of that approach is that you can get kind of binary information. So a stimulus is either seen or not seen, so you don't have this granularity. Here's a small decision guide on how to apply these new microperimetry techniques in AMD. So if you have a slow progression of absolute scotoma and you believe that you can stop that type of progression, so if your therapy is really about stopping RPE atrophy progression, then what I showed you last, this high density supra-threshold perimetry testing or defect mapping, is the best approach because it's really the most pragmatic approach to test progression of absolute scotomata. Vice versa, if you have a drug or therapy where you believe it can somewhat stabilize function in the junctional zone or maybe even improve function in the junctional zone with dysfunctional photoreceptors, then this approach of using these patient-tailored microperimetry grids makes a lot more sense, because then you can really focus on this junctional zone and use the time to go through all the steps of the staircase strategy to also find minor relative changes in sensitivity. And in the field of intermediate AMD, if you aim to target individual high-risk lesion in an eye, like to follow a large druce with pigment over time, then obviously this approach of targeted perimetry is the approach to go. Last, I will talk on color vision testing in AMD. So here the literature is actually quite complicated because it's very heterogeneous, given that there are inconsistencies in terms of the tests and equipment used across studies. And then the second major issue is that some studies compensated for lenticular senescence, because the yellowing of the lens typically causes an effect along the triton axis. However, other studies did not do so. Comparing those cross-sectional studies, the most common feature is actually elevated triton thresholds in all kind of stages in AMD. There's a hallmark study from Jeffrey Arden from 2004, and what you can see in the upper right corner is a panel plotting acuity on the x-axis and color vision thresholds on the y-axis. And if you just look to the left part in the plot, where you still have normative acuity, you can see that their proton thresholds are typically normative. However, triton thresholds can already be severely impaired even in the presence of normative BCVA. It's also another large study coming from London from 2017, which you see in the lower two panels. And again, you see for different AMD severities on the x-axis, the red-green dysfunction and the yellow-blue dysfunction. And again, you can see that the yellow-blue dysfunction is much more severely affected. However, regarding color vision, there are only very few studies investigating change over time. Here's one example from the Duke feature study, which was the largest prospective study with refined phenotyping in AMD that also included color vision testing. They included this automated Ray-Ban cone contrast test, which is one of the most rapidly performable color vision tests in clinics. It basically shows optotypes with either red, green, or blue cone contrast on an isochromatic photopic background, and over time this contrast decreases, and once the patient isn't able to see the optotypes anymore, that's how the color threshold is defined. And here you can see again in the uppermost row the results for the red, in the middle row the results for the green, and in the lowermost the results for the blue cone contrast test. And then in the panels from the left to the right you see normal eyes, eyes with early AMD, and then eyes with intermediate AMD. And the first thing which is noticeable, that if you just look across the panels in all row, there's actually not huge differences between normals and early AMD. That mostly overlaps. There's a slight color vision dysfunction in the intermediate AMD column. And then if you look in the change over time, so that's these different boxes within each panel, then you can see that there's actually relatively little change over time. There was only significant change over time in intermediate AMD eyes for the red and green cone contrast test, but not for the blue cone contrast test. And that's, by the way, directly contradicting the majority of the previous literature, which again shows how complicated color vision is and that there is so far no clear consensus regarding the data. To summarize, microperimetry enables precise quantification of retinal dysfunction, particularly in the junctional zone of geographic atrophy. Studies in the past have too frequently used standard grids and standard approaches, and we can do better these days. For atrophic diseases, especially geographic atrophy, depending on the action of the drug, you should either select or go for patient-tailored perimetry if you want to look for relative effects or even function improvement in the junctional zone, or if you want to slow RPE atrophy and that's your main treatment outcome, then high-density suprathreshold mapping is the most pragmatic way. And for focal progression in the context of intermediate AMD, like slowing the progression from a large drusen to nascent GA, targeted perimetry is the most pragmatic approach. And the utility of color vision testing to document change over time in AMD is still unclear, so that's why there's not a strong evidence base to apply it in clinical trials. Thank you very much. Please feel free to reach out to us if you have any questions.